Most people believe diabetes announces itself through a blood test. You sit in a clinic, a number comes back above a threshold, and that is the moment you find out. That belief is understandable. It is also one of the primary reasons so many people miss what their body has already been communicating for months, sometimes years, before that number ever appears on a lab report. The truth that the research supports, and that most patients are never told directly, is this. The body begins producing warning signals of chronically elevated blood sugar well before any standard diagnostic threshold is crossed. And the first place those signals consistently appear is the feet. That connection sounds unlikely until you understand the biology behind it. By the end of this video, it will make complete sense. And the 9 signs covered here will change the way you examine your own feet, a simple practice that takes 60 seconds and that the evidence suggests could be among the most valuable health assessments you perform. The American Diabetes Association estimates that more than 8 million Americans currently have diabetes and are entirely unaware of it. They feel well. They are active. They have no symptoms they would describe as medical concerns. Meanwhile, chronically elevated glucose is quietly producing damage to nerves, kidneys, eyes, and the circulation serving the extremities. Damage that accumulates over years before it becomes dramatic enough to force a clinical visit. The 9 signs that follow represent the body's early attempts to signal that this process is underway. For each one, most people have a ready explanation that has nothing to do with blood sugar. Those explanations are often plausible. The purpose of this video is to show you when the plausible explanation is insufficient and what the underlying biology actually looks like. The first sign is tingling or numbness that recurs without an obvious positional cause. Everyone has experienced the sensation of a foot falling asleep from pressure or awkward positioning. That is normal and resolves quickly when position changes. What is not normal, and what most people explain away using the same language, is tingling or numbness that occurs while sitting in a normal position, without pressure on the limb, without any mechanical cause. This distinction matters because the mechanism is completely different. Positional tingling is caused by temporary pressure on a nerve or blood vessel. Unprovoked, recurring tingling in the feet is caused by peripheral neuropathy, damage to the protective myelin sheath surrounding the peripheral nerves, produced by prolonged exposure to elevated blood glucose. The mechanism is direct. Glucose molecules bind to proteins in the nerve's protective coating through glycation, the same process that drives cataract formation in the lens and accelerated aging in the skin. As the sheath degrades, electrical signal transmission becomes distorted. The tingling is the distorted signal reaching the brain. The American Diabetes Association reports that approximately 50% of people with diabetes will develop peripheral neuropathy over the course of their disease, and it almost invariably begins in the feet first, because the longest peripheral nerves in the body, extending from the spine to the toes, are the most vulnerable to cumulative toxic exposure. The practical implication: recurring, unprovoked tingling in the feet is not a positional phenomenon to be dismissed. It is a neurological signal that warrants blood glucose evaluation. The second sign is a burning sensation on the soles of the feet, most pronounced at night. Heat from prolonged standing, warm temperatures, and physical exertion all produce foot discomfort that is easily and correctly attributed to their cause. The burning associated with diabetic neuropathy has a different character. It occurs at rest, typically intensifies at night when other sensory input is reduced, and does not respond to cooling. Cold floors, fans, or removing covers provide little or no relief. The mechanism is specific. Nerves damaged by prolonged glucose exposure do not simply go quiet. In many cases, they become hyperactive, generating spontaneous signals that the brain interprets as pain or heat in the absence of any actual thermal stimulus. The nerve is misfiring, sending an alarm signal not because the tissue is in danger, but because the signaling apparatus itself has been damaged. Research published in the journal Diabetes Care found that burning foot pain frequently presents 1 to 3 years before a formal type 2 diabetes diagnosis. The symptom precedes the diagnostic threshold because the nerve damage begins during the pre-diabetic phase, when blood sugar is elevated, but not yet at the level that triggers a diagnosis. The dietary response most directly supported by the evidence is increased fiber intake. Fiber, from vegetables, legumes, oats, and whole grains, slows glucose absorption from the gut by increasing the viscosity of gut contents and slowing gastric emptying. The resulting reduction in post-meal glucose spikes directly reduces the toxic exposure the peripheral nerves are experiencing with each meal. The third sign is a wound on the foot that is not healing at the expected rate. A cut or blister that remains open and unimproved after 2 to 3 weeks is not a wound management problem, it is a circulation problem, and in the context of chronically elevated blood sugar, it is one of the most medically serious items on this list. The mechanism operates through 2 compounding pathways. First, elevated glucose damages the endothelium, the cells lining small blood vessels, through glycation and oxidative stress. The vessels narrow, stiffen, and lose their capacity to regulate blood flow. Second, the immune response to infection depends on adequate delivery of white blood cells and oxygen to the wound site through those same vessels. When the vessels are compromised, the healing infrastructure cannot reach its destination. The biological capacity to resolve the wound exists in the bloodstream. The damaged vascular pathway prevents it from arriving. The CDC reports that diabetic foot ulcers are the leading cause of non-traumatic lower limb amputations in the United States, more than 100,000 per year. In nearly every case, the chain of events began with a small wound that was not recognized as clinically urgent. The practical protocol is simple and specific. After bathing each evening, examine every surface of both feet under good light. Between each toe, the heel, the ball of the foot, the entire sole. Any wound that is not clearly improving within 48 hours warrants a call to a physician. Not a week of observation, 48 hours. The fourth sign is skin discoloration on the lower legs and ankles, a darkening, reddening, or in some cases, a slightly bluish tone that is often attributed to sun exposure or described as something that has always been there. The mechanism is vascular. When chronically elevated blood sugar damages the small blood vessels supplying the skin of the lower legs, oxygenated blood cannot reach the tissue at its normal rate. The skin, chronically undersupplied with oxygen and nutrients, changes color. In some patients, the skin also becomes thinner and more fragile in the affected area. The discoloration is the skin signaling inadequate circulation, not a cosmetic variation. A study published in the Journal of the American Academy of Dermatology found that these skin changes are detectable, on average, 18 months before a person receives a diabetes diagnosis. The vascular damage is underway long before the diagnostic threshold is crossed and the skin of the lower legs is reflecting it. The fifth sign is chronic heel cracking that does not respond to topical moisturizers over months of consistent use. Dry heels are common, particularly in dry climates and in winter months, and most cases respond to regular moisturization. The distinction that matters here is cracking that persists year-round, that continues despite consistent application of moisturizer over months or years, and that keeps returning despite treatment. This pattern indicates that the problem is not external moisture loss, it is internal nerve dysfunction. The autonomic nervous system controls functions that operate below the level of conscious awareness, including the regulation of sweat gland activity in the skin. When autonomic nerves in the feet are damaged by prolonged glucose exposure, the sweat glands they regulate stop functioning normally. The feet lose their internal moisture source. Topical moisturizer addresses moisture on the surface of the skin, but cannot restore the internal sweating mechanism that keeps the skin supple from within. The cracking continues because the cause has not been addressed. The American Podiatric Medical Association identifies chronic heel cracking that resists appropriate treatment as a meaningful clinical indicator of autonomic neuropathy, a condition directly associated with long-term elevated blood glucose. Cracks in feet with compromised circulation are not merely cosmetic. They are open wounds in tissue that may already have impaired capacity to heal and defend against infection. The sixth sign is swelling of the feet and ankles that occurs consistently toward the end of the day, leaving visible sock impressions in the skin that persist after the socks are removed. Transient ankle swelling from prolonged standing, heat, or long periods of inactivity is common and not independently concerning. The pattern that warrants attention is swelling that occurs regularly in the evenings, regardless of activity level, that is deep enough to leave prolonged skin indentations, what clinicians call pitting edema. And that represents a change from a previous baseline. The mechanism here connects to kidney function rather than directly to nerve damage. The kidneys are responsible for fluid balance regulation throughout the body. When chronically elevated glucose damages the renal microvasculature, the tiny blood vessels through which the kidney filters the blood, the kidney's capacity to regulate fluid retention is impaired. Excess fluid that would normally be excreted accumulates in the tissues. It drains to the lowest point in the body, the feet and ankles. The National Kidney Foundation estimates that diabetic kidney disease affects approximately 1 in 3 adults living with diabetes, and ankle swelling is frequently the earliest visible sign that renal function is under stress. The seventh sign is sharp, electric, or stabbing pain in the feet, particularly at night, that has been attributed to arthritis, old injuries, or overuse. Joint pain and nerve pain are clinically distinct, but patients frequently describe both using similar language: sharp, severe, located in the foot or lower leg, which leads to years of anti-inflammatory treatment for a problem that has a neurological rather than a structural cause. Damaged peripheral nerves do not always go quiet as they degrade. In many cases, they become hyperactive, generating spontaneous pain signals in the absence of any mechanical stimulus. The pain is real, it is not psychological, but its source is a misfiring nerve rather than an inflamed joint. Anti-inflammatory medication does not address nerve hyperactivity. It reduces inflammation that is not the primary cause of the symptom, while the underlying nerve damage continues to progress. A landmark study published in the New England Journal of Medicine found that painful diabetic neuropathy affects approximately 25% of people with diabetes and is frequently misattributed to musculoskeletal causes for years before the correct diagnosis is made. The distinguishing features are the nighttime predominance, when competing sensory input is reduced and nerve signals become more prominent, and the electric or stabbing character, which is more consistent with nerve misfiring than with joint pathology. The eighth sign is feet that remain persistently cold, regardless of ambient temperature, insulation, or the warmth of the rest of the body. Feet that are cold in cold environments, or transiently cold and then warming normally, represent normal physiological response. Feet that remain cold in warm environments, under blankets, while the rest of the body is comfortably warm, indicate that adequate blood flow is not reaching the extremities, not because of environmental temperature, but because of vascular disease. The mechanism is peripheral arterial disease, narrowing and stiffening of the arterial vessels supplying the lower limbs, produced by the same endothelial damage driven by chronic glucose elevation that impairs wound healing and skin perfusion. The blood is warm. The vessels carrying it to the feet have narrowed to the point where adequate volume cannot reach the extremity regardless of the thermal demand. The American Heart Association identifies diabetes as the single largest risk factor for peripheral arterial disease, which affects more than 8 million Americans. Persistently cold feet in all conditions are among its earliest consistent warnings, appearing before the more dramatic symptoms of claudication and rest pain that typically prompt clinical evaluation. The ninth sign is one that is almost never included in patient-facing health information that most people have not looked for, and that becomes unmistakable once you know what to observe. Hair loss on the lower legs and the tops of the feet. Hair follicles are among the most metabolically active structures in the body and require a continuous, adequate supply of oxygenated blood to function. When peripheral vascular disease reduces blood flow to the lower extremities, the follicles in those areas are progressively undersupplied. They do not die abruptly. Over months and years, they gradually stop producing hair. The hair thins, then it disappears from the lower leg and the dorsal surface of the foot while remaining normal higher on the leg. Research published in the journal Diabetes, Obesity and Metabolism found that hair loss in the lower extremities correlates significantly with peripheral vascular disease in patients with diabetes. It is a recognized clinical sign that physicians are specifically trained to examine during foot assessments, one that most patients have never been told to look for themselves. 9 signs. Each one individually has a common, innocent explanation. Feet fall asleep. Skin gets dry in winter. Feet run cold. Hair thins with age. Every one of these explanations is sometimes correct. What the biology tells us is that when these signs appear in combination, or when they appear in patterns that do not fit their common explanations, burning at rest that cooling does not relieve, cracking that persists despite months of moisturizer, cold feet in July, wounds that are not healing. The innocent explanation is insufficient. Something else is operating. The practical response to this information is simple and immediate. Tonight, after bathing, sit with good light and examine both feet completely, between every toe, the heel, the sole, the lower legs. Look at the skin color. Note any wounds. Check whether hair is present or absent on the lower leg and the top of the foot. Feel for numbness. This takes 60 seconds. If what you find corresponds to anything described in this video, and particularly if more than one sign is present, request a fasting blood glucose test from your physician this week. A basic fasting glucose test is inexpensive, widely available, and covered by Medicare for most older adults. It takes one blood draw and returns a result that has the potential to change the entire trajectory of what happens next. The earlier chronically elevated blood sugar is identified, the more completely its consequences can be managed, in many cases through dietary change, regular physical activity, and consistent monitoring without requiring pharmacological intervention. The damage that accumulates during the years between when the body begins signaling and when the signal is finally heard is damage that cannot be fully undone. The body has been trying to communicate. Now, you know the language it is using.